we are live streaming in YouTube, so I'll get the link and give it to you guys. I guess since we are full house, Dharma, we don't have to wait till 6, or you want to wait because it's another 3 minutes more, I guess. That's okay, we can wait. Those who have like names which are not identifiable, please change your name to the name you registered with. Otherwise, you will be put in waiting room because there are a lot of people who have registered. So can you please rename yourself? If you cannot rename, just drop us a text. We will rename for you. Like KL, PN. Yes, take the call. Hey, Prof. Adi is already here. Okay, yeah, can see Prof. Adi.
Yeah, hi. Y'all can hear me? Can you all hear me?
Yeah, I can hear you.
Can you hear me? Is it loud?
Yes, yes,
Okay,
clear.
good.
Dharma, please start. We're on time now.
Greetings and welcome everyone. As a monthly initiative, Student Council 2021 is organizing an online continuous medical education talk for the greater benefits of Manipal University College Malaysia students under the guidance of our Student Council advisor, Prof. Dr. Samsubrade. First and foremost, I would like to welcome Prof. Dr. Adi Negara, Dean of Faculty of Medicine, and Prof. Dr. Samsubrade for gracing us with their presence here today. Before we start, I would like to announce some ground rules for the CME talk. Please keep all your mobile devices on silent mode. Please refrain from eating in front of the webcam. Please ensure that you are dressed appropriately. Throughout the talk, your microphones will be muted by the host and co-host of the meeting. Please turn off your video to engage and interact with the speaker during the Q&A session. This meeting will be recorded and pictures will be taken for documentation purpose. By attending this meeting, you have given your consent for the recording and picture taking. Now we will proceed with the picture taking session. All the participants are required to turn on their webcams.
All of you, please turn on your camera, the webcam, because we'll take a picture and after that you can off the camera. Rather, we would like you to off your camera. Okay, we have 100 people here and I'm sure some of you are watching in YouTube live already. So I'll give another few seconds for you to on your camera and then we'll start taking the pictures. There are 3 pages. Okay, I guess like we won't spend any more time. So, okay, in 3, 2, 1. This is page 1. We have 3 pages to take. So just hold on. If you have your pose, just hold on to your pose. Page 2, 3, 2, 1, taken. Page 3, 3, 2, 1, taken. Back to you, Tharma.
Thank you, from Prof. Dr. Som Subrade. Now, I would like to invite the Dean of Faculty of Medicine, Prof. Dr. Adi Negara, to welcome our speaker.
Okay. First of all, can you hear me? All right. Is it okay? Can hear? Okay. So Dr. Jaspal Singh, our Vice Chancellor, MUCM, and also CEO of GVMC, and also on behalf of the institution, we'd like to welcome you to this webinar session. For that, I'd like to take this opportunity to thank the people behind it, the Students Council, Prof. Dr. Lee, do you remember during your days, Prof. Som Subra was your advisor, yeah. And he has been our advisor, I think, from the day one itself of this institution. I think we can give this as a permanent post to him, Prof. Som. So well done for that. Also would like to thank the Students Council for having this webinar session. So just to inform, especially Dr. Lee here, we've been having this webinar session almost on a 3 weekly basis. It's not even a monthly basis, even lesser than that. And over the past few months, we have had talks on public health, on dermatology. And just to inform you, Dr. Lee, I think a colleague of yours also from batch 19 by the name of Dr. Neo Rajan. You remember him? Dr. Neo Rajan? Yes. So he's also from batch 19. He gave a talk on neurology. All right. So we have distinguished speakers from batch 19. I think well done to batch 19. So ladies and gentlemen, boys and girls, I think I challenge you all to challenge batch 19 because they have a couple of alumni presenting as specialists in this who knows later, maybe down the years, some of you from batch 38 this event. So with that, again, I would like to thank them. And of course, Dr. Lee, all right, I've worked with him before. Dr. Lee, you were in Hospital Muar, right?
Right, yes.
Yeah, so I remembered him as a student, and later on, he rendered his services, ladies and gentlemen, to us as exam coordinator of Hospital Muar. All right, so thank you so much. During those times, we had the exam format of P2S1 and P2S2. Just to inform you, Dr. Lee, we have changed our syllabus and curriculum. We have included P2S3. I think during your time, it ends with P2S2, right? The semester 10. So we have shifted, just to inform you, the P2S2 to semester 9, and in semester 3, we have totally a portfolio examination. It is like Viva. So that is the P2S3. So I think, time has changed, but, we are thankful. And just to inform all, this webinar session is very important, not just for us, but also for students here, where maybe decisions can be made, or maybe even a pictorial guide to how to ascend yourself after housemanship. Because I've been telling students that you all you shouldn't stop at just being a medical officer. You should go and beyond, because the reality is that in Malaysia there is severe deficiency of specialists all across the field. All right, not just in the field of cardiology, but all across the field of dermatology, the field of the curative medicine. We require specialists, and what better not than having the CME talk. So for that, again, like to thank the organizing committee, so Prof. Somsubrade, the student advisor, and the students council headed by Pervin. I don't know where this is, and the rest of you. Thank you so much. So we hope to have this CME talk occurring at a very regular interval in spite of the pandemic. All right. So just ignore the pandemic and just listen to the talk. I'm sure it's going to be a great one, and I hope knowing Dr. Lee, I'm sure there'll be you'll be able to convert some of the students here into cardiology. So with that, again, thank you so much, Dr. Lee, to be part and parcel with us. And again, thank you so much, Prof. Som and the students' councils. Thank you so much. So over to you, Dharma.
Thank you, Prof. Dr. Hari Nagara. Now I would like to invite Mr. Elvin to give a brief introduction about the speaker of the day.
Thank you, Dharma. Now I would like to introduce our speaker for today, Dr. Lee Zhong. So Dr. Lee graduated from Malacca Manipal Medical College in 2011. He's from batch 19, like what Prof. Adi already told us, with Dean's Honor Roll for Scholastic Excellence in 2009 and 2010. Dr. Lee then joined Ministry of Health as a MOAR from 2011 to 2013. Then he worked as the medical officer, MO, in medical department in HPSF. In 2016, he successfully finished his MRCP. So he obtained his MRCP from Royal College of Physicians of the United Kingdom, and then became a physician in HPSF MOA itself. Apart from that, he was also one of the Antimicrobial Stewardship Committee in HPSF till 2019. Dr. Lee did not stop here. He continued pursuing his cardiology fellowship in Penang General Hospital from 2019 till now. Dr. Lee also has academic experience to be a tutor for MRCP practical assessment of clinical examination skills, PACES, preparatory course in HSNI Batu Pahat in 2017 and 2019. Apart from that, Dr. Lee is also one of the examination coordinators for Asian Metropolitan University, AMU, from 2017 to 2019. While serving the community as an MO and physician, he was also one of the clinical lecturers and examination coordinators for the Department of Medicine of MMC till 2019. Now that Dr. Lee is in Penang, he is one of the clinical lecturers of RCSI and UCD Malaysia campus, IUMC. So without further ado, I would like to pass the floor back to Mr. Tharma, then we can begin with talk from Dr. Lee. Thank you.
Thank you, Mr. Elvin. Now I would like to invite our speaker, Dr. Lee Zhong, to begin his presentation.
A very good evening to Prof. Adi, Prof. Adi Negara, Prof. Som, and as well as all the students gathered here today. I have very fond memories of my student days in Manipal, as well as my housemanship, MOship, as well as physician days in MOA, where I had the chance to interact with Manipal students. It is a great pleasure to be invited by the Student Council. Thank you to Prof. Som as well as the Student Council for coming up with this initiative. I think if I was a student, I would also be very interested to have alumni speaking, because I think it shows great confidence that Manipal students can do well, and to know that we have good training is during our student days. So I've been asked to speak about internal medicine because that is what I'm doing. So I think when I was a student, internal medicine was something which was very vast. There are it's a very varied discipline. You have many subspecialties, and you find that the physicians were brilliant. They could come up with a diagnosis with just history taking, as well as examination, investigations, as well as coming up with a good management plan. I found that I was attracted to it because there was that combination of a holistic treatment for patients, as well as there are a lot of groundbreaking procedures, as well as knowledge that is available as the years go by. So the pathway to internal medicine specialization, if we describe it as a road, sometimes you may see it as a straight road, but actually the road has many obstacles. Okay, so I shall talk about the technicalities first. So to become a physician in Malaysia, you need to get your national specialist registration. So in order to get that, you need the required qualification. So the recognized qualifications are the Masters in Medicine, which is offered by the universities, which is currently UKM, USM, UM, as well as UITM. Then there are the parallel pathway. So you can either take MRCP UK or MRCP Ireland. In regards to MRCP Canada, Australia, as well as the American Board of Internal Medicine, these are quite rare and not a mainstream parallel pathway. So the main pathways that most physicians pursue will be either going for masters or parallel pathway by MRCP UK or MRCP Ireland. Okay. So I shall speak more regarding MRCP because that was what I was trained for. So to give an outlook of previous MRCP UK physicians, in the past, as long as a doctor passed the MRCP UK, they were able to start practicing as a specialist, as a physician. In those times, doctors were limited. So once you pass your MRCP UK, you are considered and assumed to have the skills of a physician. But as the years go by, more and more doctors obtain MRCP UK. More and more doctors pass MRCP UK earlier. So when I was a trainee physician, my consultants used to say that they would not pass their MRCP so early, you know. But we are seeing more and more doctors passing earlier and earlier, which I think is a good sign that our doctors are equipping themselves with the up-to-date knowledge. So, but as the years go by, the ministry found that doctors need to be trained in a more structured manner. So the parallel pathway training program started to be developed, as they wanted the standards to be coordinated with the master's program. So if you go to this website, parallelpathway.gov.my, it has a very comprehensive information on how a parallel pathway trainee training is expected. So once a doctor passes part 1, they are to register with the ministry, and they are automatically considered as a pathway trainee. And the criteria is to complete training in internal medicine for 4 years from the date of passing part 1. This is a departure from previous criteria. This criteria actually came up in 2018 and started to be enforced fully in 2019. The caveat of this part one is that some doctors may pass part one very early, and thus the beginning of training becomes earlier. However, some doctors may, for some other reason, may pass their part one later, and this may cause their registration as a physician to be a bit more delayed. However, this is not a race. Each person has their own capabilities as well as own abilities. So I think this is not a race, but a journey to become a physician. So now the criteria is you have to complete training for 4 years from there of passing part one. What about those who pass part one during their housemanship? We see that more and more frequently. So then the date of training will start from the day the doctor is an MO. So the day from MO-ship, so 4 years from then. And there is a personal development plan. This is also something which is new. This is basically a logbook that you have to fill up detailing all the details regarding your training. After completing the 4 years of training, completing the logbook, which is the PDP, the doctor has to register with the ministry again, saying that they have completed treatment and the training, and then they will be sent for 6 months of pre-gazettement before being fully gazetted as a physician. So this is the point when the doctor is considered to be safe to function independently as an internal medicine specialist. So this is basically the summary of the PDP. You can get it from the Parallel Pathway website. So basically, it's a very busy slide, but basically it goes to show that the ministry is very focused on making sure that the training is a structured training, and the doctor who is planning to be a physician through the Parallel Pathway has gone through all the necessary training. Okay. So regarding MRCP UK, it has 3 parts. Part 1, Part 2 written as well as spaces. So when the doctor can attempt Part 1 of MRCP, eligibility, there's a list of criteria which you can get from the MRCP UK website, but you need to have at least 1 year in medical employment. So which is why most doctors would start to attempt for their Part 1 during their 2nd year of housemanship or during their early MO-ship. For myself, I attempted Part 1 during my housemanship. And I feel that it gives you some reassurance because once you pass your Part 1 early, you get to show to your prospective medical specialists as well as consultants that you are ready to join their department. In addition to that, preparing for Part 1 also gives you the necessary preparation for you to become an MO as well. But that said, again, this is not a race, it's a journey. So you should attempt it once you feel you're ready enough. Okay, MRCP UK Part 1 has 2 papers, 3 hours per paper, and it's a best of 5 format, no negative marking. 100 questions per paper. Okay, so it covers the range of all the subspecialties in medicine, but interestingly, it also, most importantly, it covers clinical sciences, which is your basic sciences, which number of question 25, which is further divided into the table on your far right. So it has those topics which most of you would have undergone in your 1st and 2nd year: anatomy, biochemistry, physiology, genetics, statistics, and so forth. With respect to Part 1, I feel that as a graduate from Manipal, I feel that the things that I learned from 1st to 5th year, 1st to 5th year means 1st year, 2nd year, you learn your basic sciences, anatomy, biochem, physiology, some genetics and immunology. These concepts were well drilled into our knowledge early on. So when I was attempting my part 1, I felt that Manipal prepared me well for my part 1. Statistics, I think I think we have one of the best statistics professor in Prof. Adi. I think you can't beat that anywhere. So I feel like whereas most people would give up on statistics, most of my friends who take part 1, they will just give up the 5 questions and say they will focus on the rest. But I felt that the lessons we learned in Manipal were very more than adequate for our training in attempting part 1. Okay, that's it. Then we move on to part 2 written. There's 2 papers, 3 hours per paper, 100 best of 5 questions, about the same, but it's more clinical. It's more clinical. So you can see from here, the basic science is no longer there. But of course, these concepts of basic science are still there in all the questions subsequently. With respect to this, it's more clinical and the questions are longer. They have more scenarios, more x-rays, more ECGs, more pictures. And when I took my part 2, it was 3 papers. So you guys are lucky, it's now 2 papers if you're planning to take MRCP part 2 written. Last time it was 3 papers over 2 days. So you really get a very big headache after the end of examination. Once you pass your part 2 written, then the next thing left would be a PACES. So PACES is the practical part of our MRCP UK examination. So there's 5 stations. So first station will be respiratory and abdominal, short cases. Station 2 is history taking. Station 3 is short case again, CBS and neuro. Station 4 is mainly a com skill, which is mainly a talking station. Station 5 is a combination of history and examination, which is called a BCC. Again, with respect to our training in Manipal, I think it has prepared us well. When I started practicing for short case, most of the techniques were already trained during my student years. So for those aspiring to take medicine, do start to think about how well you want to do your short cases, as well as take proper history. I think our training in Manipal prepares well for that. Okay, so once you pass your MRCP UK, then you will have to go through the PDP and all that. MRCP Island is another pathway that some people take. I can't really comment on which is easier because there are people who take both for some reasons or other. Some people just want their name to become longer. So MRCP Island, the eligibility is 6 months. So compared to 1 month for MRCP UK, there's also 3 parts. And the main difference is that it has long cases in the final part. Regarding masters, it's the main pathway actually recommended by the Ministry of Health. There's there's a long list of eligibilities, but the most important thing that you have to note is that you need 3 years of SKT more than 85. SKT is our performance. Once you start working as a doctor, you will have a performance review by your consultant or your boss every year. So they will give you a mark. So you need at least 3 years of SKT more than 85%, which depends on your working environment as well as your consultant. So by 3 years means that you need to work for at least 3 to 4 years before you can start to apply for masters in medicine. There is an entrance exam which consists of MCQ and as well as interview. The system is either open or closed system. So means that some master's candidate, they spend all their 4 years in university, which has its pros and cons. Closed system, you spend half of it in other hospitals. Example, let's say you spend half in HKL or Serdang, then after that you spend another 2 years in university. Well, so you can imagine that masters is more taxing because you really have to commit yourself to the training program. And once you pass your masters, then you need 6 months pre-gazettement as for MRCP UK. So I showed you a picture of a long road, which looks quite unobstructed, but in reality, the road to becoming a physician is not that straightforward. Most of the time, you'll find yourself going through very lonely, dark days. So you winding road. Sometimes you don't really know where you're going. Sometimes you may find that there's a lot of distractions. When you're a student, your focus on your academics may be more clear. But as you start working, you will find that working life comes with its own set of challenges. You also need to start thinking about family. I suppose telling you young people now, it may not be so relevant. You may not feel it, but once you start working, you will start have the other commitments, other challenges, family, marriage, children, other commitments. Exams may not be that straightforward, multiple attempts, and working life is not the same as a student life. So these are the things that you have to keep in mind, not just in medicine, but working life in general. So how to overcome this? You need to find your passion. I think this is quite an understated statement. Whenever you ask what specialty should you do, or what subspecialty should you do, the very cliche answer is find passion. But I think this holds very true. You need to find something that you love doing, because once you start working, with all the distractions, the challenges, you need to have a reason why you're doing what you're doing. How to do that? I think you, as students, you should start to think about what you want to do now. Like Prof. Adi said, don't just settle on being an MO. You should aim to become a specialist, subspecialist, find your area of niche. May not necessarily be clinical, you may want to do something non-clinical, but then find your passion. Go for attachments, find role models. I managed to take these pictures when I was back in MOA. So with Prof. Lakshmi, as well as Prof. MV. I think I look like a student when I stand beside Prof. MV. Still very scared. So need to find mentors, role models to guide you, to tell you why you're doing what you're doing. Go for attachments. See for yourself what you want to do. Let's say you feel like you want to do cardiology. During your student days, for your attachment, you may say you want to go to IJN. So to see if you like it or not. Or sometimes you may think that cardiology is cool, but once you start seeing how it's actually practiced, you may find yourself even more drawn to it. You may find that it's more awesome. It's train, equip yourself. I think our Manipal training has always been very solid. For that, I'm very thankful for. Talk to people. So if you want to be a physician, talk to physicians, ask them how is it like, to get a feel of how it's like. So I think that's a summary of the pathway to become a physician. Actually, the pathway doesn't end there. After you become a physician, then you will start to think of doing subspecialty. Then the road becomes even longer. Then subspecialty, like for myself, I'm doing cardiology training now. The road then even branches out into which subspecialty that I'd like to do. Like, would I want to do interventional, electrophysiology, heart failure, and so forth. So it never ends. So again, as Prof. Adi mentioned, aim high, and we have all the ingredients in Manipal to succeed. So I should talk about ECG. I actually asked the organizers if I can ask questions. So who likes ECG? I think quite difficult in this webinar to have a show of hands, right? But ECG is something that as a medical student, you are required to know. If you enter the wards, most of the time you will get called to do ECGs, right? I at least during my time, when you go to the ward, they are so busy with so many things. They'll say, student, come do ECG. Then the seniors will tell you, the reason we ask you to do ECG is so that you know how it's done and you know how to interpret it. during that time, I felt like they were kind of bullying us. But as time goes on, actually it holds true. You need to know how to do an ECG for you to interpret it properly. Okay, so I should talk a bit of some technical aspects, some fast heart rates, slow heart rates, as well as some miscellaneous ECG that I feel that you should know as a medical student. So in case you are joining a medical quiz, such as Neurobytes, maybe they'll ask this. Augustus Waller was the early inventor of the ECG. This is Jimmy, his dog. So he used to go on road shows showing his new gadget, which is an ECG. So he used to do an ECG of his dog called Jimmy. So last time the ECG was very cumbersome. It was big machine that was not very practical. So, but now we have so many new devices. Apple Watch, and the one on your right is Cardiac, which is a device which can detect for any arrhythmias. So to know ECG, you must have an idea of a normal heart conduction system. So back to your physio as well as anatomy, our heart conduction, the normal heart conduction starts from the SA node, and the impulse travels to the whole atrium, causing atrial depolarization. The impulse also tracks down to the AV node, atrioventricular node, of which the impulse further travels down the bundle of His, separating into the right and left bundle branches, Purkinje fibers, as well as the ventricle, causing ventricle depolarization. So that ECG is basically a record of how the electrical activity is moving in the heart. So like the story of the many blind men holding the elephant, right? So that is the reason you do so many different leads for your ECG, 12 lead ECG, because you want to see the heart from different angles. By seeing the heart from one angle, let's say you only have one lap AVR, you won't be able to actually accurately describe what's the electrical activity of the heart. So a basic principle is if the impulse is traveling towards the electrode, so the arrow towards the blue point will be the electrode, you will give a positive deflection. If the electric activity is moving away from the electrode, then it gives a negative deflection. And if it's somewhere in between, so the impulse is, the electrode is just as the area where the impulse is neutral, so you will get a biphasic wave. So this is the main principle. Okay. So so the different electrodes help us to look at different areas of the heart. Okay. So by looking at different areas of the heart, we can able to tell from which axis the heart is moving. Okay. Sorry, some technical thing. Okay, so to know how to do ECG is so important. You need to know where to put your the LEDs. Okay, so V1 to V6. I'm sure all of you know this. Okay, it's important because sometimes you may get a strangely different ECG, and your nurse or someone doing the ECG may have put the electrode at a different area. So you must know where to put all these leads. Then sometimes we may do right-sided leads if we suspect some right ventricular involvement. Same goes if we may do posterior leads, so you need to know where to put these leads. Okay. So from the chest lead, then you also should know where to put your limb leads as well. Okay. So by putting the electrodes at different position, you are able to get the heart the electrical vector from different angles of the heart. Okay, so why I'm emphasizing this is because sometimes the electrode may be placed in a different position, or it may be reversed, and you will get very strange ECGs that you don't know how to explain. Example would be this ECG. It looks quite normal, right? It looks regular. You see the PQRS. It's not tachycardic or bradycardic. But one thing that should strike you as weird should be the positive deflection in the AVR. That should not happen. In AVR looks at the heart from the right shoulder from the right side. So the total vector of the electrical activity of the heart should be away from the AVR. So it should be a negative. So when you see this ECG, it should immediately strike you as this is a wrong leg placement. Okay. And it's also important to know where to place your leads properly, not just in the position, but make sure the area is clean. There's nothing that can cause disturbance. In this case, you will see very strange looking waves. So a less experienced person may say, oh, this looks like a ventricular fibrillation, very bizarre LEDs. But then look properly and you will notice that the main electrical disturbance seems to be happening at LED 2 and 3. However, keeping in mind that the ECG is printed at the point of time. So the LEDs that are being printed 1, 2, and 3 are supposed to be at the same time. So it doesn't make sense that LEDs 2 and 3 have these bizarre waves, but LED 1 has a perfectly normal sinus rhythm. So this should immediately trigger your mind to say that this is likely an artifact, rather than jumping and thinking that this is a VF. So artifact reduction is so important. Okay. Also, check your ECG calibration. If you look at your ECG, right, you will notice on your left side, you will see this kind of tower-looking kind of structure. So that is the calibration. So if your calibration is not the normal calibration, which is 1 millivolt equals to 10 mm, you may find that your ECG QRSs as well as your P waves become very tall or very small. Okay, so make sure this is being calibrated. Paper speed is also important, 25 millimeters per second, because it will help you to decide regarding the rate as well as duration of the waves. And this 25 mm per second is usually printed right at the bottom of your ECG. Okay, so to interpret ECGs properly, you need to have a systematic approach. So you need to make it a habit. I think for your chest X-rays, I think the radiologists always like to ask us to describe chest X-rays by saying the name first, right? This is an X-ray of who and who. ECG is also the same. Make sure you are not mixing up with the different patients. Sometimes when you start working so many patients, and the ECGs may get jumbled up. So make sure systematic, name and ID first. Make sure it's the correct name, correct ID, time and date. Make sure it's calibrated well. Then you start to count the rate. Okay. I find that during my working experience so far, a lot of housemen do not know how to count the rate in an ECG. So you must know how to count the rate from the ECG. So it depends on whether the rate is regular or irregular. If the rate is regular, you can use various different formulas. But what I like to use is you divide 300 divided by number of big boxes between the RR. So if the RR interval is, let's say, 3 big boxes, then your rate is 300 divided by 300. Okay. Of course, you may have different methods of counting, but this is the method that I find that gives me is quite simple. Okay, so 300 divided by number of big boxes. So if the number of big boxes between the RR is 5, then your rate is 60. Okay, but then this criteria only applies if the patient's rate is regular. If it's irregular, in the event of patient having atrial fibrillation, then this 300 divided by number of big boxes of the RR does not apply. Okay, so if the patient has atrial fibrillation, you have to use a different method. There are a lot of different methods, but the method that I like to use is to count the number of boxes. So you know that your strip is running at 25 mm per second. So then one small box will, because you know that your one big box is 1 mm, right? So one small box will equals to 0.04 milliseconds, 0.04 milliseconds. Then 5 big boxes will equals to 5 small boxes means 1 big box will equals to 0.2 milliseconds. So a total of 30 boxes, 30 big boxes will equals to 1 second. So you count 30 boxes. Then after that, you count the number of complexes within the 30 boxes, which is 1 second. Then you will get your rate per minute. Okay. Everyone got that right? I hope you do. It's not that difficult. Okay. Then you look at the rate, at the rhythm. Is it regular or irregular? I mean, if you have any more, you have questions regarding how to count this, you can ask me during the Q&A later. But then I feel that this is something that all of you should know, so that when you start working, if your MO or specialist asks how to count the rate, so please raise your hands. I'm a Manipal grad. I know how to count rate for AF. Okay. Cardiac axis also quite important that you should know. PI interval, QRS complex, D wave, and ST segment. Okay, so you must know the normal intervals. PR is usually 3 to 5 small boxes. If it's more than that, then you are thinking of a patient with a heart block. Specifically, more than 200 milliseconds would be first degree heart block. QRSs, not more than 3 boxes, so not 3 big boxes, not more than 0.12 milliseconds. And QTC, difference in men and women. Okay, you must know your QRS axis, because then you can decide whether there's left axis deviation or right axis deviation. How to know the axis? You can know by looking at the leads. So if let's say your patient has positive in lead 1 and positive in AVF, that would mean that the vector is at the bottom right corner. Okay, then the axis is normal. However, if the AVF is negative means that the axis lies on the top 2 boxes, and if the one is positive, means that the axis will lie on the top right corner, which is a left axis deviation. So usually when you want to decide what is the axis, you look at LET1 and AVF. Okay, to show what I was talking about. So you look at LET1 is positive, and as well as the AVF is negative, that would mean that it's a left axis deviation. Then if the LET1 is negative, means the axis shifts to the left side, to the left side, and the AVF is positive, the axis lies on the bottom left corner, which is a right axis deviation. Then you may ask, what if 1 and AVF are both negative? In that situation, number 1, you should make sure your LED position is done correctly. Sometimes it may be reversed. Another possibility is an extreme axis, which can happen in a patient with a deviated heart, or patient having a rotated heart, or patient may be having a ventricular tachycardia causing extreme axis. So lead orientation, this is something that you should know. 2-3 AVF is inferior leads. Lateral leads are 1 AVL, V5, V6. This as well as V1 to V4 are anteroceptor leads. This is basic that all house officers should know, because this would help us to manage a very common disease in our medical wards, which is ischemic heart disease. You want to know the area of ischemia. I shall go on to some arrhythmias. So basically you have the tachyarrhythmias as well as bradyarrhythmias. I shall show some ECGs, but generally be systematic when reading ECGs. Go through what I showed just now. You have to go through one by one, and it will help you in order to come up with a diagnosis. Unstable arrhythmia, always treatment will be cardioversion. Pharmacotherapy is the next line, as well as you should know what is the latest in our cardiology world, which is catheter ablation therapy, which is potentially curative. So I should start. I think in the interest of time, I should go through very quickly. This is an ECG of a sinus tachycardia patient. You can see the PQRSs are normal. And once you see this, you know it's normal. Once you go to the next slide, then you will find that it becomes abnormal, right? So this is a narrow, complex, regular tachycardia. And you may notice, I'm not sure why my cursor is not moving. But anyway, QRS, you see there's a small bump after the QRS, which is negative deflected. So this showed that there is a P wave buried there. So you may wondering where's the P wave? The P wave is there. So this is an example of an SVT, re-entrant tachycardia. A re-entrant tachycardia means the re-entry comes at the level of the AV node. Okay. So this is another example of a re-entrant tachycardia. So you have narrow complexes, regular tachycardia. When these patients are reverted into sinus rhythm, you may find that this is a typical ECG. So you may find that there's a short PR with a delta wave. Delta wave is an upslurring of the R wave. Upsloping of the R wave. This shows that this patient has an accessory pathway. So the impulse travels from the atrium to the ventricle in a very fast manner. Your AV node has a property to guard the impulses traveling from the atrium to the ventricle. But then when you have an accessory pathway, it becomes like a highway, you know. The electric can travel very quickly down. That's why the PR interval is very short with the upslurring of the R wave. So don't forget this short PR, delta wave. Then sometimes you may get more scary looking ECG. This becomes a broad QRS. Still, this is a SVT, which is an AVRT. But because the impulse travels down the accessory pathway, the complexes become broad. So it's an antidromic AVRT. Okay. So when you get a patient with a SVT, so means narrow complex tachycardia. The differential will be, number one is sinus tachycardia, AVRT, AVNRT, atrial fibrillation, atrial flutter, or atrial tachycardia. Okay, so these are your differential when you get a patient with SVT. I think sinus tachycardia, most of you can differentiate out. So the 5 things that you need to know: AVRT, AVNRT, atrial fibrillation, atrial flutter, as well as atrial tachycardia. So when you get this kind of patient, the first thing you should decide is whether the patient is stable or not. If not stable, then you have to go for cardioversion. If patient is unstable, then you may try vagal maneuvers first. Then if it doesn't work, then you give IV adenosine. I hope all of you by your 5th year should know how to administer IV adenosine. IV adenosine is a very short-acting drug. It blocks the AV node. Is given through a large bore IV cannula. Usually we put over the brachial, and is injected very quickly down the line. Then during that procedure, you need to tell the patient what you're doing. Patient may feel sensation of choking or shortness of breath, but this is something very transient, at most 6 seconds. At the point of you doing it, you must have cardiac monitoring. Okay. Long-term wise, you may control it with medications, but you have to remember that we have newer treatments available now. Catheter ablation is something that you should know, at least in theory. Okay, this is an ECG that you will encounter a lot as you do more medicine. This is a patient with atrial fibrillation. You see that you don't really see very discrete P waves, right? And you see the baseline fibrillating. You may argue that it may look like atrial flutter. So you are not wrong to say that, but usually atrial flutter waves are more pronounced in like this ECG. You can see the very classical sawtooth pattern. So atrial fibrillation, atrial flutter is something that as a medical student or house officer, you should know how to manage. So must know the causes of atrial fibrillation. You should be able to discuss what's the difference between rhythm control versus rate control. If you go through the latest studies, it's more in favor of rhythm control nowadays, because you know that reverting the patient to a normal sinus rhythm is always better than keeping the patient in atrial fibrillation. You must know regarding stroke risk stratification, chest 2 VAS score is a must. You must know and discuss, as well as the types of oral anticoagulation available. Again, catheter ablation is something very exciting. We are able to revert the patient back to sinus rhythm with catheter ablation. Then we go on to the tachys. This is a scary ECG, which is a ventricular tachycardia, broad complex tachycardia. Then this is a ventricular fibrillation. Then you can see the classical torsade de pointes changes. So you can see the undulating, twisting pattern. So if you see this ECG, all the LEDs are in congruence, means it all is happening together. It's not an artifact. You should immediately assess the patient, make sure patient is stable or not. Most likely unstable, then you need to shock the patient. Okay, so long-term wise, treatment would be ICD for secondary prevention, medication such as beta blocker, and in certain patients, we may consider catheter ablation. Okay, you see, so medicine is very exciting. We can do a lot of newer things. We go on to a bit of Brady's. You should not miss this. The PI is prolonged. So this is a first degree heart block. Okay. Then we move on to the morbid type 1. You see wanky backing. So you see the PR becoming more and more prolonged before a missed beat. And the immediate QRS, PQRS complex, the PR is short. Okay. So you see prolonged, drop beat, and the beat after the drop beat is a short PR. So this is classical for a morbid type 1. Whereas morbid type 2, you will see no change in the interval. Okay, I hope you know that. And in this ECG, you see a 2-to-1 block. And now this is a patient which, if you go by it systematically, you'll notice that the P waves are behaving very strangely. It's not talking to the QRS. If the ECG is, if the electrical activity is going down the normal pathway, it should be a normal PQRS. But you notice that the P is not in electrical agreement with the QRS. So it seems like it's not coming together. Then if you plot it properly, you'll find that there is AB dissociation. So this is pathognomonic for complete heart block. AB dissociation. So you can see all the P waves there. Some are buried in the QRS, some are buried in the D waves. Okay, last ECG. I'm sorry, we can't, I really have to go a bit faster. This is an ECG that you should not miss. This is an ECG of an ST elevation. So you can see ST elevation over the anterolateral LEDs, okay, with reciprocal changes. So whenever you see ST elevation, look for reciprocal changes to confirm your suspicion of an ST elevation MI. Okay, so I hope that I've kind of piqued your interest in doing medicine. Medicine is never easy, but a smooth sea never made a skilled sailor. So I'm very happy to speak to all of you today, and I'm happy to take any questions.
Thank you, Dr. Lee, for the very informative talk. This has definitely broadened our perspective on cardiology, and I think we can all agree that the information regarding basics of ECG interpretation and approach to cardiac arrhythmias was insightful. Due to time constraints, we have minimized the number of questions to which we want to highlight on. The remaining questions will be sent to Dr. Lee through WhatsApp, and his answers will be shared later. Now I would like to call Ms. Kanchana to conduct the Q&A session.
Good evening to everyone. So today I'll be conducting the question and answer session. And due to time constraints, we have limited the number of questions to 3 questions. And the remaining questions will be sent to Dr. Lee through WhatsApp. So the first question is how to differentiate an AVRT and an AVNRT. Okay, so I think I went through that part quite quickly. I think for you it would be quite confusing. Both of these will cause narrow complex regular tachycardia unless of, okay, so I shall explain. AVNRT, there is a re-entrance circuit
through the AV node. Whereas AVRT, there's an accessory pathway. How it behaves for an AVRT depends on whether the impulse is traveling through the accessory pathway. If the impulse is traveling from the atrium to the ventricle via the accessory pathway, it's called antidromic AVRT. Antidromic. If the impulse is traveling down the AV node and back up to the atrium via the accessory pathway, is an autodromic AVRT. How to differentiate these two? Typically, AVRT, you will get the typical pre-excitation. So I see a question there. Is delta wave always linked to WPW syndrome? Yes. Most of delta wave signifies pre-excitation. So there is something that causes the impulse to travel more quickly from the P to the QRS. So it means from the atrium to the ventricles. Okay, so typically AVRT would have a delta wave. AVNRT, because the reentrant circuit happens within the AV node, so it's a very short duration. Okay, a very short duration. You can imagine the impulse from one side, you will give one impulse to the ventricle, one impulse to the atrium. So when you get the SVT ECG, you'll find that the RP interval is very short, which won't be seen in AVRT. Okay. But how to differentiate these two? There are many other ECG characteristics, but these are the main things that you should know. I think at your level, it's not wrong when you see a patient with a narrow complex regular tachycardia to give the differential. You can say this is an SVT differential, either AVRT or AVNRT. Is accepted for students.
Okay, thank you, sir. So the second question is how to see reciprocal changes on ECG.
Okay, reciprocal changes means that whatever the ECG is seeing from one direction, in the mirror image, you would see in the opposite direction, you would see the opposite changes. Example, I showed you an ECG of an ST elevation of the anterolateral lens. Okay, so the means that the infarct is occurring over the anterolateral area. So you get ST elevation there. So the mirror image would be 2-3 and AVF. So 2-3 and AVF will get depression. Similarly, if you have ST elevation over your inferior lens, you will get ST depression in the reciprocal, means you will get ST depression 1 AVL, or you may get ST depression over the anterior lens. So this is important because this will confirm that indeed there is an ST elevation. Sometimes you may see some non-specific ST elevation, then there's no reciprocal changes, then that would be less likely to be an MI. Okay, but it's a general rule.
Okay, and the last question was, what was the most challenging case you have seen throughout your career and how did you manage it?
Right, I would say, I think the most challenging cases would be cases that have difficult diagnosis. There are so many, but I have one patient that was a young lady with very difficult to treat heart failure. Okay, we did all the workups done. You know, when you have a young patient, it becomes even more critical for you to do your best for the patient. Unfortunately, we didn't manage to save the patient, but the journey was there. You know, you travel along with your patient, and it taught me what it meant to be a doctor lah. It's not just treating the disease. You start to treat the patients. You start to talk to the patient, talk to the family, explore their expectations. Sometimes patients also know that we don't know everything and we can't treat everything. So that was a very humbling experience to know that medicine sometimes is science and as well as an art.
Okay, sir. So there are no questions from the YouTube live, and that's all from me. Back to you, Tharma.
Thank you, Ms. Kanchana. Thank you, sir. Now I would like to invite Mr. Wiswam to give the word of thanks.
Thank you, Dharma. First and foremost, on behalf of Student Council, we would like to express our gratitude to our speaker, Dr. Zhong for his time and insightful talk. Next, we would like to thank Professor Dr. Adi Negara, Dean of Faculty of Medicine, Manipal University College, Malaysia, for making time to attend this talk. Of course, a big thank you to the Student Council members for their efforts into making this talk happen successfully, along with the guidance from our advisor, Professor Dr. Som, for ensuring the success of our talk. Thank you to all the participants for attending this continuous medical education, and I hope to see everyone again in the upcoming session.
Thank you, Mr. Viswam. All right, I think we can conclude our session here today. Thank you all participants and student council members for making this event a memorable one. Hope to see everyone in the upcoming CME talk.
Thank you very much.